بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على رسوله الكريم سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, now we are starting a new series in the diagnostic radiology in English dealing with abdominal imaging. And as you remember, we have finished some of the lectures about brain imaging and some of the lectures about chest imaging, and now we will start this series, which is composed of about 12 lectures about the abdominal imaging. And as usual, we'll start by discussing the anatomy, then we'll go deep into the pathology of different abdominal organs. Then you know that the abdomen can be imaged by so many techniques, including the X-rays, the ultrasound, the CT scan, the MRI, and some of the radionuclide imaging techniques, as well as the angiographic techniques usually performed by CT or MRI, and also we have some of the interventional techniques. Then one of the major diagnostic modalities in assessment of the abdomen is the CT scan. Of course, the battery of imaging will start by ultrasound, but the CT has a major role in evaluation of the abdominal organs. Then as you all know that I have little experience in ultrasound imaging, so I cannot explain in detail the value of ultrasound, but I can show some of the examples whenever the ultrasound is good and relevant. And the indications for examination of the abdomen by CT include so many items, and the first of them and the most important one, in my opinion, is to assess an equivocal imaging finding. And the usual scenario is a patient who is complaining of abdominal thumping is subjected to an ultrasound examination, for example, and the report of the ultrasound was not that conclusive and recommended to be followed by a CT scan of the abdomen. And many situations like a barium study, which was not so that conclusive, IVB, and so many of the investigations, but commonly the ultrasound. Then whenever there is a hepatic neoplasm, and a staging of this neoplasm will require the help of CT. Also in assessment of metastatic workup of primary malignancies, whether in the abdomen or outside the abdomen, in diagnosis of abdominal masses and differentiation between solid and the cystic, location of the mass in a specific organ, and so on. And we have a separate lecture about the value of or the imaging of the biliary system, and we'll discuss the value of CT in this domain. As you all know, with the advent of multi-detector CT, now the patients can be imaged non-invasively, and you can see any of the vascular structures and vascular lesions inside the abdomen or outside. And one of the most important indications for CT nowadays is post-traumatic evaluation. And you remember that in the previous days, most of the patients with abdominal trauma will go directly to the surgical department for exploration if they have a suspicion of internal bleeding, for example. But nowadays we can image the patient in a few seconds using the multi-detector CT, assessing different abdominal organs, and we can see the bleeder, and this will be exposed in a separate lecture which will deal with abdominal trauma. Then in order to perform in the CT of the abdomen, in the previous days we used to prepare the patient with administration of a diluted oral contrast known as gastrografin. and this contrast was diluted by water, and the patient drink this contrast orally a few hours before the examination, aiming to opacify the intestinal loops, as you can see. And while the patient is lying on the CT table, he may drink some of this contrast media to opacify the stomach as well. Then this was an essential part of the examination, this type of preparation, because it helps us too much to identify some of the pathologies which will not be able to identify without the administration of this oral contrast material. And this is an example where you can see that some of the intestinal loops are normally opacified by the orally contrast media, by the orally administered contrast media, while other intestinal loops are not opacified, and indicative that there is some pathology here and which requires further evaluation. And this is another example where you can see a mass in the abdomen, and through this mass you can see an opacified bowel loop going inside this mass, indicating that this mass should be of intestinal origin, and you have to look for this loop of intestine, whether it is a small bowel or large bowel, in order to reach the differential diagnosis. And also this is an example of the value of contrast media. If you can see this abdominal CT without oral or intravenous contrast material, and you can see some of the intestinal loops, and you may feel that these may represent loops as well. But after administration of oral and intravenous contrast, and you can see these are the intestinal loops, and this is the root of the mesentery containing the superior mesenteric artery and the vein, and these are lymph nodes around the root of the mesentery, and considering their pattern of enhancement, we can assume that they are of inflammatory nature. Then in order to do a CT scan of the abdomen, the patient lies on the CT table, and we should have a scanogram. And the scanogram is just a plain X-ray, or similar to the plain X-ray, of the part to be examined. And we would like to examine the abdomen. We order the CT to have the scanogram, and the CT will ask about the type of the scanogram, whether it is frontal or lateral. And of course, in the chest and the abdomen, we should have a frontal scanogram in order to identify the plane of scanning. And we put two lines like this. The first one indicates the start of the exam, and the last one indicates the end of the exam. Then we would like to examine the abdomen from the level of the diaphragm until the level of the pubic symphysis, and this is known as CT scan of the body, or CT scan of the abdomen and pelvis. And we have another type of examination where we scan the abdomen from the diaphragm to the level of the iliac crest, and this is known as CT scan of the abdomen, and is directed mainly for evaluation of the liver, the spleen, and the pancreas. Then before starting the examination, we should decide if we are going to inject the patient with intravenous contrast material or not. And the contrast material used for CT examination of the abdomen and the chest as well are those contrast material used for intravenous urography, like urographene, Telebrex, Urovizone, Isovest, and so many other contrast media. Then we used, before starting the examination and before injecting the patient with contrast, we look for the clinical data. Why we are scanning the patient, what is the organ of interest, what is the provisional diagnosis, and so on. And if the organ of interest was one of these, the liver, the kidney, or the urinary bladder, then we should have a pre-contrast scans. That's to say, we scan the abdomen before injection of contrast, then we inject the contrast, and we start scanning once more. And the pre-contrast scans are very valuable, and I will explain this in a moment. Also, with the development of the multi-detector CT, we have to examine the liver in particular in this triphasic study, where arterial phase and portal phase as well as delayed phases are obtained after contrast injection. And I think I explained this in a lecture in the chest sector, but I will repeat some of the facts here. The scanogram, as I have said, is a frontal scanogram, and the scan intervals used for the abdomen in general will be a 10 millimeter scan interval, and sometimes it is 8 millimeter, no problem, but consider a 5 millimeter scan interval whenever you are examining the pancreas, the suprarenal glands, and the renal bladder. These structures are usually small, and if you have 10 millimeter scan interval, you will not examine these areas accurately, as I will show to you. Then look at this study, and you can see here that the aorta is containing contrast media, also the IVC containing contrast media. Then this is a post-contrast scan. And if you look carefully in the liver, you cannot see any focal lesions. Then look at the pre-contrast scan before injection of contrast media. Then you can see 2 focal lesions in the liver. Then this is the value of obtaining the pre-contrast scans before injecting the patient with intravenous contrast. Because if you start the exam after injection the patient with contrast media, you have the chance to miss some of the focal lesions, which will enhance as similar as the normal hepatic parenchyma. Then if you look here, and you can see that the patient is injected with contrast media and the liver looks normal with no focal lesions, and the pre-contrast scans will show a big lesion in the right hepatic lobe, as you can see. Then we agree that any patient who is examined for liver pathology should have a pre-contrast scan, then a post-contrast scan. Then look at this example where the liver is markedly enlarged, and this is the pre-contrast scan, and this is the post-contrast scan. And if you look carefully throughout this liver, you can hardly appreciate some of the focal lesions. But look at this image, which is also a post-contrast scan, and you can see 2 many focal lesions scattered throughout the liver parenchyma. And the difference between this scan and this scan is this scan is obtained while there is maximal concentration of the injected contrast media in the arteries, and so we call this the arterial phase. And there is a rule which says that most of the hepatic pathology is supplied by the hepatic artery, while the normal liver parenchyma is supplied by the portal vein. Then in order to see the hepatic focal lesions at clear enough, and you detect most of the lesions and you will not miss of any of the lesions, and you should have this arterial phase. And this arterial phase was not feasible before the development of the multi-detector CT, because the older scanners and the spiral CT were very slow to obtain such images. And with the development of multi-detector CT, we are able to order the machine to scan the patient while the contrast media is in the artery, then to scan the patient while the contrast media is in the vein. Then we wait for 2 minutes, and we have what's known as the delayed phase. Then we'll go to the triphasic study. And this is an example where you can see this is the pre-contrast scan, which is obtained routinely before any examination of the liver, where you can see a focal lesion here. Then look at the arterial phase, where the contrast media is maximally concentrated in the aorta, and you can see enhancement of the focal lesion as well. Then in the portal phase, with this arterial phase is taken about 20 seconds after contrast injection, and this portal phase or venous phase is obtained about 50 seconds after contrast injection, and the delayed phase is obtained 2 minutes later. And look here in the portal phase, you cannot see the lesion, and also in the delayed phase, you cannot see the lesion. Then we should know that any enhancing lesion in the arterial phase should be considered as pathology, since the hepatic parenchyma will enhance in the portal phase and in the delayed phase. And you should know that most of the vascular neoplasms of the liver will wash out the contrast media very rapidly. They accumulate or take the contrast media rapidly, and the contrast is washed rapidly also from the lesion. Then look at this example. This is a pre-contrast scan. The liver is cirrhotic and the spleen is enlarged. Then this is the arterial phase, and you know the arterial phase by the very bright appearance of the aorta, which is almost similar to the spine adjacent to it. Then look at the focal lesion, which is enhancing in the arterial phase. And in the portal phase, it is relatively masked, while in the delayed phase, it is clearly seen. Why in some patients you can see the lesion in the delayed phase? Because the lesion will wash out the contrast, or the contrast media will be washed out from the lesion very rapidly, while the liver is still accumulating the contrast media. Then you got the difference between the two densities, and you are able in some cases only to identify the lesion better in the delayed phase, and this is not the rule. The lesion is best appreciated in the arterial phase in most of the cases. Then we'll have a quick review of the anatomy of the abdomen, and we'll emphasize some of the anatomic details about some of the organs. And you see here the upper cuts, where you can see this is the liver to the right side, and this is the spleen to the left side. And if you give the patient with contrast, oral contrast, you expect that the stomach will be distended with this contrast media. But after the multi-detector CT, we do not need to prepare the patient with gastrografin, except in few cases where the gastrointestinal tract is our interest. Then here, this is the liver, and this is the stomach, which is collapsed, containing some fluid, and this is the spleen. And here you can see the aorta, and you can see the IVC. Lower down, this is the liver once more, and here is the aorta, and this is the IVC, and these are the diaphragmatic crura. The left cross is relatively thinner compared to the right one, and they surround the aorta, as you can see, and this is the spleen, and this is the stomach. Lower down, you will see the pancreas, and here is the pancreatic body and the tail, and this is the spleen, this is the stomach containing some of the orally administered contrast media, and this is the liver, this is the aorta, and this is the IVC, and here you can see the upper bowl of the left kidney. Then look at this section. You can see the spleen, you can see the left kidney, you can see the right kidney, and you see the aorta, this is the IVC, and this is the liver, this is the gallbladder, and also you can see the stomach containing air and some orally contrast media, and these are intestinal loops. Then lower down, you will see the head of the pancreas, and the head of the pancreas is identified by these two vessels, which are the superior mesenteric artery and the superior mesenteric vein. Although the artery and the vein are much smaller than the pancreatic head itself, but they are considered the most reliable anatomic landmark for identifying the region of the pancreatic head, especially whenever the patient is not taking oral contrast media. Then this is the pancreatic head, and then this very small hypodense focus represents the common bile duct, and this is the duodenum, as you can see, adjacent to the pancreatic head. And these are small bowel, and these are large bowel. This is the remaining part of the liver, this is the left kidney, and this is the right kidney. And you can see here, this is the left renal vein, which is crossing anterior to the aorta in order to join the IVC. Sometimes this renal vein may cross behind the aorta. This is known as retro-aortic renal vein. And this is one of the informations which should be given for in the report of patient performing renal angiogram as donor for renal transplant. Then this is the region of the pancreatic head, and this is the left kidney, this is the right kidney, and this is the aorta, and this is the IVC, small bowel, large bowel, and the last area of the liver. After finishing the liver, you are here only, you can see here only the intestinal loops, and they are containing the orally administered contrast media. And in many situations, you can easily differentiate the small bowel from the large bowel. The large bowel contains a lot of air and fecal matter. The small bowel does not contain air in many cases, and there is no fecal matter, of course. Then lower down, you can also see the small bowel and the large bowel. This is the psoas muscle, and this is the iliacus muscle. And you can see that the aorta has divided into two common iliac arteries, and the common iliac has been divided into the lower down into the external and internal iliac arteries. And if you came to the pelvis, you should discriminate between the male and the female pelvis. And here is the male pelvis, where you can see this is the urinary bladder. Posterior to it are the seminal vesicles, and this is the rectum, as you can see. Anteriorly, you will see the rectus abdominis muscle, which is one of the famous muscles of the anterior abdominal wall. Then lower down, you will see the prostate, and you will see the anal canal. And you can see these two linear shadows, which represented the anorectal sling of the levator ani muscle. And lateral to it, you can see this triangle, which is filled with fat, and this is the ischial fossa. And this is, of course, one of the famous muscles in the pelvic floor. This is the obturator internus muscle, and this is the prostate, as you know. Then if you came to the female pelvis, and you will see that here, look at this image, and you can see this is the urinary bladder, and this is the uterus, and here is the colon. And you know that the fundus of the uterus and the body of the uterus are above the urinary bladder, while the cervix is present between the urinary bladder and the rectum. Then this is the body of the uterus, as you can see here, and this is the cervix, which is located between the urinary bladder and the rectum, as you can see here. Then we will discuss some of the details about the anatomy of specific intra-abdominal organs, starting by the liver. You know that the liver is divided into two loops by a line joining the IVC to the gallbladder, like this one. And here is the left lobe, and this is the right lobe. And the left lobe is further divided into two segments, the lateral segment and the medial segment, by the fissure for ligamentum teres. The lateral segment is away from the liver, and the medial segment is close to the rest of the liver. Then the right lobe is divided into an anterior and a posterior segment by a horizontal line from the IVC to the lateral abdominal wall. And this is the anterior segment, and this is the posterior segment. And you know that the segmental surgical anatomy will divide each of these segments into two segments. One is above and one is below, like this. And this is the surgical segmental anatomy. This is the left lobe, and this is the right lobe. And you know that the left lobe is formed of the lateral segment and the medial segment. The right lobe is formed of the anterior segment and the posterior segment. Each of these segments is divided once more into two segments. One is above and one is below. Then you should know that the part of the liver which is located between the portal vein and the IVC is the caudate lobe, and this is segment number 1. Then in order to know the segmental anatomy, you should identify the level. If you are above, you are cutting in these areas. If you are below, you are cutting here. Then the landmark for the lower segments is the pancreatic tail or the splenic vein posterior to the pancreas. Whenever you see this, you know that you are cutting in the lower segments, and then you are cutting here 3, 4, 5, 6. Then look at the section. This is segment number 3, and this is number 4. This is the fissure for ligamentum teres, and this is segment number 5, and this is segment number 6. Then if you are in the above segments, and the anatomic landmark for the above segments is the IVC lying in its fossa on the inferior surface of the liver. And whenever you see that the IVC is very close to the liver parenchyma, especially in the above sections where you can see that the hepatic veins are entering the IVC here, I will say this in a moment, then you are cutting in the above sections. And these are in the above segments, and these are the above segments number 2, 4, 8, 7. Then this is segment number 2, and this is number 4, and this is number 8, and this is number 7. Then whenever you look to the liver, you should not see any focal lesion. The liver density is almost similar to that of the spleen. And you remember, this is the fissure for ligamentum teres, and this is the lateral segment of the left lobe, medial segment of the left lobe, anterior segment of the right lobe, posterior segment of the right lobe, and the caudate lobe. Then if you look to the liver and you see a lesion which is containing water or fluid, and this is known as a cystic lesion, and a lesion which is containing solid material like this, and this is a solid lesion. In the lecture of hepatic imaging, this is a very important diagnostic finding in order to identify or to diagnose hepatic focal lesions. You should first identify whether the lesion is containing fluid or the lesion is made of solid material. And this the patient, of course, you have 2 renal cysts, and you can see also multiple radiopaque stones within the gallbladder. Then if you look to this example and you see fluid containing lesions in the liver, and you know these are cystic lesions, and most of the cystic lesions in the liver are benign. And if you look to this example and you see a solid lesion, and most of the solid lesions in the liver are malignant, I will discuss this in details in the lecture of hepatic imaging. Then if you look to the liver, and you should identify that the liver density is almost similar to that of the spleen. But if you see that the liver is hypodense compared to the splenic parenchyma, and this is due to deposition of fat in the liver, and this is what we call fatty liver. Then if you see that the liver is shrunken with a regular lobulated surface, and this is the cirrhotic liver, and you can see also ascites, and you can see the spleen is relatively bulky. Then if you see that the liver is very dense compared to the spleen, especially if the patient is not injected with contrast media, and this is what we call the storage diseases, hemochromatosis, hemosiderosis, and so on. Then the liver which is hypodense compared to the spleen, and the patient is injected with contrast media, this is fatty liver. And the liver which is hyperdense compared to the spleen, and the patient is not injected with contrast media, and these are the storage diseases, hemochromatosis, hemosiderosis, and so on. Then in the liver parenchyma, you should not see any hypodense lines or tubes or shadows. You can only see these hyperdense structures which represent the vessels containing the injected contrast media. But if you see linear hypodense shadows, you know that these are dilated biliary radicals, and the normal bile ducts are not seen by CT, but the bile ducts are seen whenever they are obstructed and dilated. Then you can look at this liver and you say that these are obstructed ducts, and this is a case of biliary obstruction. Then you should go further to, I will discuss this in details in the lecture of biliary imaging, and looking for the site of obstruction and the cause of obstruction. But the initial diagnosis should be this is biliary obstruction whenever you can see multiple linear hypodense shadows going throughout the liver parenchyma. But if you see hyperdense shadows containing the contrast media, you know that these are vessels. And you have three types of vessels crossing through the liver parenchyma: the hepatic artery branches, the hepatic veins, and the portal vein radicals. And of course, you should not see the hepatic artery branches unless you are in the arterial phase. And this is the arterial phase, and if you see some linear shadows containing contrast media like this, and these are branches of the hepatic artery. Then in order to identify the hepatic veins, look at the level where the IVC is located in the visceral surface of the liver, and you will see three main vascular channels entering the IVC, and these are the superior, middle, and the inferior hepatic veins. And this is the only section where you can see the hepatic veins. And any vessel crossing through the liver parenchyma after that is the portal venous radical, and this is the hepatic artery branch, which is only seen in the arterial phase, and these are the hepatic veins which are only seen at this level, and the rest of the vessels will represent the portal venous radicals. And at the porta hepatis, of course, or the hilum of the liver, you can identify the portal vein. Then this is an old technique which is known as the splenoportography, and we used to introduce a needle percutaneously into the spleen, and we inject a lot of contrast media aiming at the delineation of the portal venous system. And this is the site of injection through the spleen, and this is the splenic vein, as you know, and this is the superior mesenteric vein, and here you can see the portal vein, and you can see multiple gastroesophageal varices in this area. And of course, this examination is no more performed in the clinical practice after the development of multi-detector CT, where you can have this non-invasive technique which is known as the CT portography, and you inject contrast media intravenously and design your scanning to obtain sections throughout the portal vein when the contrast media is in the portal vein. Then you reconstruct the image, and you can subtract any of undesired structures like the liver, the pancreas, and any other, and you are left with an image like this. This is the spleen, this is the splenic vein, and this is the superior mesenteric vein, and this is the portal vein and its radicals. Then these are two examples where you can of CT portography, and this is the splenic vein, superior mesenteric, portal vein, and you see a thrombus in the portal vein. And this is another example of cirrhotic liver, splenomegaly, and esophageal varices seen by CT portography. Then if you look to the liver, you should not see any focal lesions, and I should emphasize this finding in particular because it is usually mistaken for hepatic focal lesions, and they are just artifacts. Whenever you see focal lesions on either side, on one side or on both sides of the fissure for ligamentum teres, and you can ignore these as artifacts. And especially in patients with non-primary malignancy, don't mistake these lesions as metastases, because they are only just artifacts, and they may be located on one side or in both sides, as you can see here. Also, the indentations of the diaphragm on the hepatic surface like this one, and they may be mistaken as a focal lesion, and this is just an indentation of the diaphragmatic copula or leaflet on the surface of the liver. And the porta hepatis contains three major structures, and these are the hepatic artery, the portal vein, and the common bile duct. And of course, the most commonly seen structure is the portal vein, and you can see some fat, and one of these structures may be the hepatic artery, but using special techniques you can see the portal vein, and you can see the hepatic artery, and you can also see the common bile duct. Then few words about the pancreas. And the pancreas lies obliquely in the abdomen. The tail is above and the head is below. Then while you are coming from above downward, you will hit the pancreatic body and tail first. Then lower down, you will see the pancreatic head. But sometimes the pancreas lies horizontal in the abdomen, and in the section you can see the pancreatic tail, the body, and the head as well. And you remember that the vessel which is running along the posterior border of the pancreas is the splenic vein. and this is the remaining part of the spleen, left kidney, right kidney, aorta, IVC, and the liver. Then here you can see this is the pancreatic body and the tail, and this is the splenic vein running along the posterior aspect of the pancreas. Then lower down in the section below, and you can see the anatomic landmarks of the pancreatic head. These are the superior mesenteric artery, and this is of course the superior mesenteric vein. This is the artery which is smaller, and this is the vein which is relatively large. And you remember, this is the left kidney, and this is the left renal vein crossing in front of the abdominal aorta to join the IVC, and this is the right renal vein. Also, you can see the gallbladder, which contains a big stone here, and you can, if you look to the aorta, and you see a vessel coming from the anterior aspect of the aorta. And you remember, there are three vessels coming from anterior aspect of the aorta: the celiac, the superior mesenteric, and the inferior mesenteric. In the usual abdominal scans, you cannot see the celiac artery because it is short, and you cannot also see the inferior mesenteric artery because it is thin. Then the only vessel seen in regular abdominal scans coming from the anterior aspect of the aorta should be the superior mesenteric artery, and this is the superior mesenteric artery. Then the pancreas is usually of almost similar or less dense than the liver and the spleen, and is located obliquely, as I have said, in the abdomen. And in old age, the pancreas gets atrophic and is infiltrated by fat, and this will not affect the pancreatic function, and it's expected to see a pancreas like this in old age, and this is normal finding or an aging process related to the pancreas. The peripancreatic fat balloon should be clear, as you can see here, but if you see that the pancreas is swollen and the peripancreatic fat balloons are dirty or stranded or smudged, then you assume that you are dealing with a case of acute pancreatitis, and we have a separate lecture for imaging of the pancreas. I will explain this in details. Then the suprarenal glands are located above the upper bowl of the kidney on either side, and they look like the inverted Y. This is the left suprarenal gland, and this is the right suprarenal gland. Each of these glands will have a stem, a medial limb, and a lateral limb. Then this is the typical appearance of the left suprarenal gland, inverted Y configuration, and this is the right suprarenal gland. And you should know that the suprarenal glands are hardly identified in pediatric patients and in very thin patients as well. But in patients with adequate retroperitoneal fat, you can easily identify the suprarenal glands and you see the normal anatomy. Then this is a good example of the normal appearance of the suprarenal glands. This is the left one and this is the right one, where the lateral limb is usually masked by the adjacent hepatic parenchyma, but still you can identify that this is the normal suprarenal gland. Then lower down in the abdomen, you don't see any anatomy except for the mesenteric fat and the intestine, the small and the large one. And this is the remaining part of the liver, as you all know. Then if you look carefully along the anterior border of the psoas muscle, you can see this left ureter, and this is the right ureter containing the contrast excreted by the kidneys. And here is the intestinal loops, which are opacified by the orally administered contrast media. And here is the aorta, and this is the IVC. Then one of the diagnostic values of MDCT is to reconstruct the images and to have a CT angiogram for a specific part or a specific organ. And you look for this female patient with a mass in the left hypochondrium, and in order to identify the origin of this mass, you may have these reconstructed images. Then you know that the mass is originating from the lower bowl of the kidney, and the CT renal angiogram confirmed that this mass is malignant. You can see the hypervascularity and you can see the malignant circulation. Then the same rule applies for the liver, can be applied here also for the kidney. If you see a lesion containing fluid or water, and this is cyst, and this is benign. And if you see a solid lesion, and this is the solid lesion, which is the mostly malignant one, with few exceptions, and I will explain this in details in the lecture of the renal imaging. And this patient had 2 lesions in the left kidney. One is cystic, meaning it's a benign lesion, and one is solid, which is a renal cell carcinoma. Then this is the difference between a cystic lesion in the kidney containing water, and this is simply renal cyst, and this is a solid lesion in the kidney representing a renal cell carcinoma. And these are 2 different examples of a simple renal cyst in the left kidney and a solid tumor in the anterior aspect of the left kidney. This is renal cell carcinoma, and this is simple renal cyst. Then one of the advantages of MDCT is the ability to perform the virtual endoscopy. And this virtual endoscopy is performed for any hollow organ like the trachea and bronchi, the colon, the small bowel, the vessels, the cochlea, and many of the structures where you can perform at the urethra, the esophagus, too many structures. And I give you a single example about the virtual endoscopy of the colon. In order to perform this examination, then you should prepare thoroughly the patient to clean adequately the colon from any fecal matter, because fecal matter will appear like masses inside the colon on the virtual endoscope. Then after cleaning the colon, the patient came to the CT room, lies on the CT machine, and you inject some or introduce some air inside the colon to distend the colon. Then you have the scans. And after you have the scans, you do not need to inject any contrast media or to give the patient oral contrast material. Just you inject some air into the colon. And then you have the reconstructed images. Then you order the CT to remove all the undesired structures, and you are left with the colon. And this is considered the roadmap for the virtual colonoscope. Then in order to do this colonoscopy, you should push the button on the machine, which is indicating the virtual camera. Then whenever the virtual camera is open, like you will see here, then you put your pointer here at the start of the colon. Then you go inside the colon, and on the opposite screen you can see the images. And here you are introducing your virtual endoscope inside the colon, going through the descending colon and the rectosigmoid area. Then you realign your camera in order to go into the adjacent loop, as you can see here. Then you can pass carefully here and go until you finish the whole chronic segments. Then after that you can have special images for the regions of interest if there is any pathology, and you can also provide the patient with the CD where the examination is fully presented on this CT scan. Then here are a few questions for you about the what I have said in this lecture, and you know that this is, of course, is the pancreatic tail, and this is the left kidney. And if there are two, left and right organs, you should specify the left and right one, and this is very important in reporting cases. And this is, of course, the right suprarenal gland, and here is the portal vein. Then this is the spleen, and this is the posterior segment of the right hepatic lobe. And if you want to know the segment number, and this is segment number 6, because this is the pancreatic tail, and here is segment number 3, number 4, number 5, and this is number 6. Then this is the lateral segment of the left lobe, or segment number 3. Then here you can see this is the right ureter entering the renal bladder, and this is, of course, the cervix. And this is not the prostate. The prostate is inferior to the renal bladder. while the cervix is posterior to the urinary bladder. And here is the rectum, and this is the urinary bladder. And in this section you can see this is the left ureter, and this is the aorta, and here is the colon. And the diagnosis of this case is fatty liver, because the liver is hypodense compared to the spleen, as you know. And then this arrow points to the pancreatic tail, and these are intestinal loops, possibly the large one. And here is the splenic vein, which is crossing posterior to the pancreas, as you know, and this is the site of the right suprarenal gland. And in this case, you see multiple hypodense linear shadows crossing through the liver, diagnostic of biliary obstruction. And of course, this is the left seminal vesicle, and this is the urinary bladder, and this is the rectum, as you know. And here you have a cystic lesion in the liver, which is a benign cystic lesion, and a solid mass in the kidney. This is a malignant renal cell carcinoma, and this is a cystic benign lesion in the liver. Then dilated biliary radicle throughout the liver are diagnostic of biliary obstruction. And in this case, you see multiple hepatic focal lesions. They are solid. These are metastases. And here is the IVC, and you see the hepatic veins entering into the IVC. Then this is the IVC, and this is the inferior hepatic vein. And you know that these are the segments, the superior segments. And you remember their number, and this is segment number 2, and this is number 4, and this is number 8, and this is number 7. This patient is not injected with contrast, and the liver is dense compared to the spleen, and this is like storage diseases or hemochromatosis or hemosiderosis. Then look here, and this arrow points to the artery, which is only seen coming from the anterior aspect of the aorta, and this is the superior mesenteric artery, and this is the portal vein at the porta hepatis, and this is the IVC, and here is the left suprarenal gland, and this is the intestinal loops. This is not the pancreas. The pancreas is here, and these are intestinal loops, and this is of course the spleen. Then this is an example of coronal reformatted image for CT scan of the kidneys, and you can see simple renal cysts on both sides, as well as solid lesion in the lower bowl of the left kidney, diagnostic of renal cell carcinoma. Then few words about the value of MRI in the abdomen, and this is very important because we will expose the importance of MRI in the abdomen whenever we are evaluating the specific organs like the liver, pancreas, and the kidneys, and so on. Then in order to examine the abdomen by the MRI, and you should have the surface coil, and the phased array coil is one of the important coils which are used for abdominal imaging. Then the protocol of examination will include axial T1 and T2 weighted images, axial T1 in phase and out phase weighted images, which is very important for fat detection. Then coronal T1 and T2 weighted images, axial T2 fat suppression may be obtained, and in cases of the liver, you may have the dynamic post-contrast axial scans or the triphasic study. These are the sections in the abdomen, and this is T1 weighted image. You see the fluid is black, and this is T2 weighted image. The fluid is bright, and you can see that the liver is relatively bright in the T1 and relatively dark in the T2 weighted image, while the spleen is somewhat of similar signal intensity. Here you see the aorta, and you can see also the IVC, and this is the stomach, and these are the bowel loops. Then this is the triphasic study, the pre-contrast T1 weighted images, the arterial phase, the portal phase, and this is the T2 weighted image. Of course, you should have the triphasic study whenever you are dealing with hepatic pathology, as similar as what has been mentioned in the CT scan. Then these are the values of MRI whenever you are examining the abdomen. One of these values is the heavily T2 weighted sequences, which are beneficial for the diagnosis of hemangioma, as I will explain this in details in the lecture of the hepatic imaging. Actually, you know that hemangioma will appear of low signal intensity in the T1 and the high signal intensity in the T2, similar to any focal lesion. But whenever you are confronted with the patient with primary malignancy, and you should decide if this focal lesion will represent a hemangioma or a metastatic deposit, you should have what's known as heavily weighted T2 image. And in this image, you will got the brightness of the hemangioma, which is almost similar to the CSF, while the rest of hepatic metastasis will, the hepatic deposits will show drop of the signal in this heavily T2 weighted sequence. Then in cases you see a focal lesion on the CT scan in the liver, and you are suspecting that this lesion is containing fat, meaning that it is lipoma or angiomyolipoma, for example, and you want to be sure that this lesion is containing fat. One of the ways is to have the ultrasound, which is relatively sensitive for detection of fat, and you can see this is this echogenicity is the echogenicity of fat. And in MRI, you can see that the fat in the T1 weighted image will be of bright signal, and if you have a fat suppressed sequence, this signal will be suppressed as well, confirming that it is made of fat. Then the in phase and the out of phase images are specific for the diagnosis of microscopic fat, the fat which is not seen by the naked eye. If you look here, and this liver is relatively bright, and the liver is usually bright in the T1 weighted image. But if you are suspecting that this is fatty liver, and you should have the out of phase T1 weighted image, and if the liver is fatty, you will got this darkness in the liver parenchyma, indicative of the of being containing fat. Also, if you see a lesion in the in phase, in here you see this focal lesion, and which is not actually clearly identified in this T1 weighted image, but in the out of phase image, and you see this area of low signal representing microscopic fat in this part of the liver. And of course, this is very important imaging technique in evaluation of the adrenal adenomas, especially the lipid-rich adrenal adenoma. And you see here, this is the suprarenal mass on the left side by CT scan. And this mass looks hypodense and it does not enhance. In the T1 weighted image, you see an intermediate signal of the lesion, and in the T2 weighted image, you also see an intermediate signal of the lesion. But in the out of phase image, you see very dark appearance of the lesion, indicative of fat content. And the detection of fat is very important for confirming the diagnosis of adrenal adenoma, especially in patients with primary malignancies suspected to give metastasis to the adrenal gland. And if you are in doubt that this is adenoma or metastasis, and you should have MRI, especially in the out of phase images where the signal will drop markedly, confirming the content of fat and confirming also the diagnosis of adrenal adenoma, and no need to biopsy this lesion once more. Then in the CT scan, you see, I have mentioned that the liver is, whenever it is fatty, and the liver is relatively hypodense compared to the spleen. Then what happens if this liver contains metastasis? And the metastasis, as you know, in the liver will be also of hypodense appearance, then the hypodensity of the liver will mask the hypodensity of the metastasis. But in the MRI, the fatty liver will be bright, while the metastatic deposits will be black because of the water content. Then you can easily detect the metastatic deposits without contrast injection on the background of bright liver, which is fatty. And the detection of metastasis in the fatty liver are somewhat difficult, especially by the CT scan. And here you can see an example. This is the CT scan of a patient with metastatic bronchogenic carcinoma, showing multiple hepatic and bony deposits. In the liver is fatty, but you can see this area which is not containing fat, and this area also. And you may suspect that these are areas of fatty sparing. But on the triphasic CT study, and this is arterial phase, and you can see that these lesions are enhancing. And you remember that the normal liver parenchyma does not enhance in the arterial phase. Also, if you look to the small focal hepatic lesions and you are not sure about the nature of these lesions, whether they are cystic benign lesions or they are solid, may represent metastasis, especially whenever the patient is having a primary malignancy. But in the MRI, in the T2 weighted image, the cystic lesions will have very bright signal due to the water content, while the metastasis will not appear so bright like these lesions, and you can easily say that these are simple cysts not representing metastatic deposits. Also, one of the values of MRI is the non-invasive evaluation of the biliary system, and this is an ERCP showing multiple radio-bay filling defects representing calculi throughout the common bile duct. But non-invasively, you can have this MRCP, and in another patient, of course, and you can see multiple filling defects within the gallbladder representing stones, as well as a small calculus at the terminal portion of the common bile duct. Also, one of the values of MRI is to discriminate between regeneration nodules and hepatocellular carcinoma in cirrhotic liver. And you know that the regeneration nodules, because of the content of hemosiderin, will appear black in the T1 and in the T2 weighted images, while the hepatocellular carcinoma, because of the water content, will appear bright, relatively bright in the T2 weighted image. Then you see here in this T2 weighted image, these black foci will represent regeneration nodules, while this focal lesion will represent the hepatocellular carcinoma because of its different signal. Also, if you look to the CT images of a polycystic disease of the liver, you are seeing here multiple cystic lesions affecting both hepatic lobes as well as the kidney. Then one of the values of MRI is to detect hemorrhage inside the cystic lesions. CT is not able to detect hemorrhage, especially if it is old, but MRI can detect hemorrhage like this. You see this blood with fluid level in one of the big cysts. The value of this is to explain the patient complaint. You know that a patient with polycystic disease of the liver may be asymptomatic and suddenly develops a severe abdominal pain, and this pain is related to recent hemorrhage inside one of the cysts. And if the hemorrhage is recent, it can be seen by CT, but if it is relatively old, it can be seen by MRI. Then if you are not able to inject the patient with contrast in CT scan examination, you can assess the vascularity using the MR images or MR angiographic images. And you know that there are two main situations where you are not able to inject the patient with contrast in the CT scans, and these are the poor renal function and the major sensitivity to contrast medium. And here this is the case of esophageal varices surrounding the aorta, and can be easily identified on this MRI T2 weighted image without the need to inject contrast medium. Also, the invasion of vascular structures by vascular carcinoma and by renal cell carcinoma, for example. You see here, this is the IVC with the tumor thrombus inside the IVC, and this is a vascular carcinoma with tumor thrombus in one of the hepatic veins reaching the IVC as well. And this is one of the major advantages of MRI over CT, is the assessment of vessels without the need to inject contrast medium. And here is an example of left-sided renal cell carcinoma with invasion of the renal vein and invasion of the IVC as well. And this can be seen in the flow-sensitive techniques or even in the MRI images. Also here, the detection of iron overload, like in cases of hemosiderosis and hemochromatosis. In the CT scan, the hemosiderosis or hemochromatosis are diagnosed by the detection of hyperdensity of the liver compared to the density of the spleen, and the patient is not injected with contrast medium. But what happens if the liver and the spleen are involved by hemosiderosis or hemochromatosis? Then this is the value of MRI. And this is hemosiderosis or hemochromatosis or iron overload of the liver and the spleen. And you see the very dark signal of both organs, and you know that the muscles are not involved by iron deposition. Then if the liver or the spleen or both are very dark compared to the signal of the muscle, and you can assume the possibility of iron overload. هذا وبالله التوفيق والحمد لله رب العالمين والسلام عليكم ورحمة الله وبركاته.